I'm here at the North American Menopause Society at the annual meeting, and I am speaking with
JoAnn Pinkerton.
And you are?
The Executive Director for the North American Menopause Society and a Professor of Obstetrics and Gynecology at the University of Virginia.
And you yesterday talked about a new position that the North American Menopause Society has published related to, or is about to publish, on hormone therapy. And I wonder if you could speak to that.
So over the past year, we've had 23 national and international experts looking at all the data that's come out since 2012, as well as going backwards, to say we want to change the conversation from lowest dose for the shortest period of time to appropriate dose, duration, type of therapy, and route of administration, i.e., let's let the doctors and the women figure out what they need to do and for how long and how to be safe.
So the original position statement, or the earlier one, put a kind of a limited concept on giving women estrogen as opposed to keeping it open to clinical interpretation.
So we looked at some special populations. For example, we now know that women who have premature menopause, whether it's surgical or chemical or genetic like primary ovarian insufficiency, have health risks if they don't take estrogen of increased heart disease, dementia, Parkinson's, bone loss, sexual issues, mood issues. And if you take estrogen until the average age of menopause, those health risks dissipate back to the normal population. So we are recommending in the position statement that anyone with early menopause who's appropriate candidate should take hormone therapy until at least menopause, and then look at the decision whether to continue.
Now, what age would you consider early menopause?
Well, so early menopause could be less than 40 or even less than 45. We have different definitions, but the point is that if you have a significant period of estrogen deprivation before 51, you might want to consider taking hormone therapy at least to menopause. So that was one. The second one is that we looked at extended duration. So there's a Beers criteria that says that women should stop taking hormones at 65 because there's an increased risk.
This is B-E-R-S.
B-E-R-S, the Beers criteria, and so women can't get it through their insurances. So we've actually looked at the data, and there's no data to support that. It is true that there are increasing risks as women age, but there's also ways to minimize those risks by careful choices of your hormone therapy. So we think that women who have persistent hot flushes or bone loss that don't want to take other types of medicines should be able to have this as an option. And so it's called extended duration. No scientific evidence that you can't continue taking the hormones past 60 or 65. You just have to be careful because there's increasing risks.
That's good news for women.
It's good news for women and providers. And then the third one, what about those women who've got the BRCA gene and they have their ovaries removed early? So there's observational evidence that those women have those same increased health risks of heart disease, dementia, Parkinson's, bone loss, and observational evidence that taking postmenopausal hormone therapy does not increase their risk of breast cancer. So their genetic risk is there, but it's not increased.
That is really important because women are so worried about their risk of breast cancer that they and many of their doctors try and avoid taking it or prescribing it.
Well, and so if we think about the breast, conjugated equine estrogen, a decrease in breast cancer cases. Synthetic progesterone increases that risk. Micronized progesterone, probably neutral. And then we have a new product on the market, which is the conjugated equine estrogen, paired with a estrogen agonist-antagonist, basidoxifene, which has now been on the market for 2 years. And we already know that it relieves hot flushes, prevents bone loss, treats the vagina, improves sleep and quality of life. And I actually presented data here that looked at, does it work as well if you're close to menopause, under 5 years, or more than 5 years? And what we found was it works equally well. Interestingly, the placebo effect doesn't work as well as you age, but the hormone therapy did. And the beauty of that is it's neutral on the breast, no bleeding, and no increase in breast density. So it relieves symptoms and is a potentially safer option for women who are worried about their breast.
And the breast density point means that mammograms are not harder to read.
Right. What we know is that particularly estrogen and synthetic progestins make the breasts more dense, so there's more callbacks and maybe more procedures. And so when you change to either a different type of progesterone or you use this new combination, conjugated estrogen and beta-doxyphene, you're not going to see that increase in breast density.
That's excellent. Anything else you want to say?
It just, it's always exciting to be at a meeting full of so many different pieces of information. We're learning a lot here, and I just encourage people to go to menopause.org or to come to a NAMS meeting. We love to see you here.
Thank you very much.